Morning, ladies and gentlemen who are in the Western world, and good evening for the people who are on my side of the world. This is our fourth webinar done by people across the globe, and there's a demand now, instead of quarterly, we can switch over to monthly, which we are seriously thinking from the month of January. I welcome Professor Moidu for this webinar, that he has taken a time out for this to share his ideas, share his knowledge with the people. And I thank the participants that they have also logged in to hear him what is about. Well, we have already published everything about Professor Moidu in our brochure and on otherwise the mass mail which was sent. As far as I am concerned, it is presumed that you know everything. There are two more people who are on this side than myself. I was in the Indian Navy as Admiral. I superannuated, and also as I have started this founder of this company called Innovation Curious, where I am managing director. I am a doctor by profession, like Professor Moidu, who is my good friend. I am also professor in a couple of universities, India and abroad. And we are focusing basically everything related to healthcare innovation to bring the healthcare delivery cost by using the technology, processes like leave, and so on and so forth, so that at the last mile it can be reached to the people who have not. We have done a project in the government of Gujarat with Sachin, which I'll just introduce you, who has done it, and he got the innovation award, and we want to do it much more in such an accessible area through where healthcare delivery costs can be reduced by various processes, by devices can be brought down, and so on and so forth. In that context, this is a complimentary webinar. We thought let's share with each other. Third person who is behind the scene is my technology partner Sachin, and he is the person who is double MTech in cryptography and other things. And we are also, he's got a more than dozen patent innovation award winner, etc. Well, you can look up all this on the website. We will not go into that much of detail, and that is what we have, a combination of that. Professor Moidu has also joined our team. We know each other for 4 decades, and that is how right from the medical college days. Now we come to the topic. The topic is of a very current interest, data-driven transformation of a healthcare innovative approach. When you talk about data, there is a huge data which is available everywhere across the globe. There is a problem of interoperability, there are legal problems, the privacy, etc. There are different aspects. So how we really convert the data into information and use it for better purpose. So this is a topic which many of the people today in India and abroad is struggling that how we can go about it. Not taking your much time, I'll be handing over the floor to the Professor Moidu. We'll be noting down your question and answers, and as per his wish, either he can answer during that deliberation or maybe at the end. In the last, again, we'll have something question answers, and then I will conclude and sum it up. Over to my friend, Professor Moidu. Thank you, Professor Moidu.
Sir, namaskar. I may be sitting in New York, but my heart is still Indian. Janam Bhumi Hirday se aati hai, and I'm so thrilled to be part of this effort you have taken on to the next level, bringing innovation in all forms to healthcare. To start the subject today, I'd like to thank people in India who have helped me ground what I have as thoughts and experiences from the United States to the applicable world of Indian healthcare. While I realize Innovation Curious is more global than Indian, I still wish to say what we think of in America can be also done in India, and it is very often done in America by Indians who have migrated here. So it would be inappropriate for me to go forward without thanking everybody, especially Sachin and Sergeant Rear Admiral V K Singh. He was not only my senior in college, but he was also my boss in the Indian Navy. And with that, I'd like to jump into the topic, healthcare transformation. Healthcare as we knew it is never going to be the same. It'll keep changing. So transformation will happen. And in every case, that transformation is driven by financial motives, either to save money for the patients or save money for the organization. So let's say we are chasing the mighty dollar. Let's have a goal. There's nothing wrong in that. And this innovation has to bring value. That's the key message I like to say. So whether we improve, how we improve care and how we improve the cost of care, the end result has to be giving more people value for what they receive. Data in that process becomes critical and is a key factor. The only difference is that some have it, some don't have it. And even when some have it, they may not have the right people who know how to interpret it. And that can be a challenge. Good example, the polling pundits in America. We had everybody saying a certain candidate would win because the pollsters introduced bias. It was more their opinions in the model than the data in the model that they were talking to. I'm one of those who believes you should look at data. It has no emotion. And if you look at data and move with data, you will always succeed. In my long journey, I was a pulmonologist, and now, after doing my doctorate in medical informatics from Sweden, I've had a very happy journey, both in academia, in industry, and when I say industry, I mean both the technology development side and what I will share with you is a long experience of operations where CEOs and COOs need the data to see how can they move the organization to be more cost effective and complementary to the care. So the 4 issues that I've listed here as challenges, I've known these challenges ever since I graduated back in '72. Why have we not been able to improve on it? The costs keep rising. The quality gets lost, unable to prove it. And we all have a very simple saying, I know quality when I see it. Excuse me? Your brain needs to have first an understanding. If you have to have the notion before you can have the cognitive recognition of what quality means. And that comes through data, measuring data at every level. And as we explode into data details, we will see more and more of it coming. We often hear about the surgery went well, but the poor patient died. That's inefficiency. Yesterday, I lost a classmate of mine, and it was traumatic in a sense for me because we were quite close. We spoke a few times every month, and when his wife called me on Sunday and said he had a massive stroke, I felt like saying, let's not struggle. Let him go. But it took 5 days before the family decided to stop the respirator. So if I'm a little emotional about quality and inefficiencies, yes, the doctors kept him breathing. He had EEG activity, but he was in deep slumber, and one wasn't sure he'll come back to right. So progress in medicine is good. The data tells us how many times can we bring such people back? Not very many. And this is where I think when we transform healthcare, we have to be true to ourselves. We have to be honest to the face we see every morning in the mirror. And therefore we have to look at new models of care and realize that we need to look at new payment systems. Yes, our president-elect in the United States has gone after the signature event of the previous president, Obamacare. They want to rip and replace. Rip is easy, replace is our challenge. So when my students ask me, what do we do? I told them, keep your eyes open, there's an opportunity. Because whatever happens, once you start drinking from the cup of data, you are not going back. They will keep looking for data to confirm their work is right. And as good health information and health informatics professionals, you will always have opportunity. I have been blessed to be in this field for the last 40 years and been successfully and gainfully employed. So why won't you? And it's mentally challenging, but extremely satisfying when you can present your data and effect change. That change is innovation to me. I'll share more of these thoughts, but as I want you all to recognize, I have deep passion for the subject, and in my effort, I want you all to get some of that passion. And as the Supreme Court Justice Oliver Wendell Holmes, whose father was the dean of the Harvard Medical School in 1900, when they changed, or was it earlier than that, when they changed the curriculum and modified it to be more modern, said once, a mind once extended with an idea never regains its original shape. As a professor, that's always my challenge. I'm here to challenge you to allow me to tell you a story. And in that story, we'll work together to find where is the future. So we went through that, and let's look at this simple highlight. A state of affairs that the world now recognizes. And this diagram comes from the CDC on the left, which tells you the cause of death in the United States based on a John Hopkins study from 2013, that heart disease is the biggest killer. Cancer follows close behind. And not so far behind, but in the third place, it's medical errors. Why do we know that? Because we can now trace the data back to find the failure mode event analysis and get to know what led us to do this. The errors from human mistakes, which when written in those papers is lost. Because in data, when you put data on top of data and then bury it, anything buried is dead, unless it's a seed. Data is a seed and is germinating and bringing to us value. In the developed countries, WHO says that 1 in 10 patients have a bad event. That's more than 3 jumbo jets crashing every day. Would you fly then? But guess what? We still go to the hospital and we have no other choice. Simple issues, if we follow better, we would stop. and we can definitely improve by reducing waste. Further on this thing is the fact that as we get digitized and focusing on these two issues of pneumonia and cardiovascular surgery issues, you have some more points that say if we do not innovate, we don't improve the communication skills, we don't improve the competencies, we don't allow people to talk, we don't have that timeout, and well, that's a basketball player speaking, so sorry. The timeout in the surgery to reassure the entire team we're doing the right thing are such simple actions. But the fact that you can record those and keep that as for posterity to understand allows us to build a stronger foundation and improving the possibilities that exist. Let's look at healthcare and digital Bharat. It is the largest growth sector in India. There is no major street in India where you don't find a corporate hospital. Beautiful, clean, shining. Pretty much comparative to anywhere in the West. You take a side street and every side street has two pharmacies. These are my observations from not very long ago. In my last trip in India, I actually was impressed by that. This is happening now, and it is being studied by people. And they believe, while it's 100 billion today, it will triple, nearly triple in the next 4 years. That means an average growth of 24, 25%, or 23 as it says. That's huge growth. But that market worth is not the important thing. The market value should have other propositions also in it, not just the spend, but the outcomes, the quality of care. And that's the transformation we need. And to manage that transformation, one must invest in digital tools and technologies. Yes, everybody says we got another EMR. EMR is just a data collection tool. You need to go beyond, and that's what I'd like to share today with you. When healthcare administrators get every morning their status reports of the utilization of services, the rooms used, the number of surgeries done yesterday, and all that, it all looks good. But to see and discern in that data what's been achieved, and more importantly, what has not been achieved, is data literacy. And that data literacy, regrettably, is not part of either the medical curriculum or conferences. It has to grow, and therefore you need to be on the literary side, emphasizing it at every level. I know all of you have had a very long day and say, man, I didn't sign up for this. Let me tell you, I'm so passionate. I actually got up and I'm sitting in my office at Hofstra University because I thank Admiral V K Singh for giving me this opportunity to reach you all. I'm very passionate about my subject, and I think each time you lose somebody near and dear, you become a little more emotional, but I'll still try to speak to you from data. Without emotion, just facts. So, this is my request. Digital adoption in healthcare is expanding, and I emphasize the word beyond electronic health record at the heart of hospital information systems. So it's beyond collecting data, beyond communicating the lab results in time, beyond taking the pharmacy order out. There has to be more done. The people are all inputting the data, but they're getting no feedback. Till somebody is not using the data they enter, You shall just have data. To make it valuable data, it should be part of their work. For that, we need to continue to innovate in the way we integrate these tools in our workflow. So here is a quotation from somebody, and that person wrote, "It is with great difficulty that they were able to obtain any hospital records for the purpose of comparison." And this person is one of our leading lights in the field of healthcare. And while that person was looking at it, she wrote and quoted this nearly 200 years ago. Think about it. Data, information, analytics are not new. We're reinventing ourselves. And it's that innovation we thought we had passed, we really never reached. It has been a mirage. I implore we all take a serious look back and maybe start a blog with Innovation Curious where we say, this is what we are doing. Any good ideas? Let's start growing each idea into an opportunity for others to share. Honestly, you're not competing with each other in the market. You have so much of need in India, so much of need for good healthcare globally, that making information a power source, good, bad, I'll not make the decision. But growing with data, I sincerely would request you to make it a possibility. So there again, it was Florence Nightingale who said this somewhere in her life, and she was born nearly 200 years ago, and even during the war in Crimea, where she made a name for herself giving nursing care and developing the field of nursing, we need to do more and find out about the data and what data tells us. For many of us, reporting is considered adequate enough. Let me put this little graph on the effort, that's the time spent, and the value proposition, that's the maturity of the models. Healthcare today takes too much time collecting data. All we do is collect data. There's not enough time analyzing results. And that leaves little time for making any actions on that data. So let's look at classic reporting. What's wrong with it? It's dead data. That opportunity to act is what it's telling you. That opportunity has gone. It's my impassioned plea to you that let's look beyond. We have to look beyond. We have to change the paradigm. And I'm working with friends at Life Trends, Device, working with the group called Cloud9 and looking at their data to see what is it we can infer. But we're only beginning the journey in India. Some things I did in my role as a CIO, Chief Information Officer at a Mid-Florida ACO, Accountable Care Organization. I shall share a little later. But the issue is, let's recognize where we are today and say, how did we change it? Let's take the effort to have somebody evaluate the time spent in data collection and what are the results, and see if we can improve it in any way to make more decisions on data, on actionable data. And that's where we are today with Cloud9. And they were kind enough to allow me to use their data. So I recognize them one more time. And this is where we should be. This is where I brought my organization in Orlando to a level where we were working on the data, and it was being done by the entire team, not at the behest of the leadership. And the data is analyzed by the end user. They know the questions, and I shall share that with you. That is the future. And the future is here. Actually, it was in the past, as Florence Nightingale did give it to us in her quotation. One more time, just to hit my point hard. I'm a professor, so I tell you what I'll tell you, I'll tell you what I told you, and I'll repeat it so that you don't miss it. Reports in current systems give you a retrospective view. With little action possible, we cannot modify the status of care delivered or the outcome. It's over. Now let's look at it. Where is it? We have to collect data from multiple places. And if the data is in paper, and if we think we can transcribe it, we're losing out because the transcriptionist is not the user of the data, and there will be data errors. So you will have data, you will improve your expectations, but the results will be disappointing. So you can take that data, put it in a data warehouse. You create metadata repositories and you create dimensions. All those are technical terms. I don't want to bother you all with that, but what I want to share with you is today with Hadoop and other technologies, we also call this data warehouse a data lake. So this is where you first merge financial information with clinical information to give you a comprehensive look. Yes, many people stop here and start generating reports of it. When you've got reports in the past, and especially when we look at our American situation with claims, we do see value a little too late. The claims come in 90 to 180 days later. So while there may be excitement to try and analyze it because it's somebody's job, the value to the patient or the system is still questionable. So building a data lake and then creating late binding data marts is where the world is heading. You create value-added proposition to the reports. And here I'd like you to look at the three aspects I've shared with you. There is gaps in care to give you the current status of patients. Last office visit, next office visit, the love now middle part that I say is so important that we have not been ever educated to see why we should follow our patients. It's only when you're in full control of your population do you recognize that anybody you have not seen, or if you look at all the admissions that happened in the last 30 days, you will go backwards and you will find that you did not see these patients for over 100 days. Chronic care is changing the way we look at disease and we look at the spectrum of care that has transformed. And in that process, you have a very simple role. As a physician, you don't focus on it, but your operations team of managers and schedulers and other front office staff, they can go and get you the patients back to see where are they before they show up in an emergency room or they are admitted with serious complications. Another dimension which we often ignore is resource utilization. These three pieces is all I'm going to add today, but there are multiple ways you can use this data, and when you mix clinical information with financial information in what I call finicles, you as administrators, as leaders, will get a view, an insight that would be startling. That's a transformation. That's the innovation I hope we see this group push forward. So Thus, we'll see the analytics in action. Reports should be there for compliance measures, for showing that you have met the quality standards you are expected to have. And that should be off the data. And that should tell a doctor, you know what, your COPD patients have an average length of stay of 8 days, and you may be taking 4 x-rays, the x-ray on admission, and if there is no clinical change, why are you repeating the x-ray every day or every alternate day? These are the questions that we need to all keep asking, and that will make an immense difference. So, once and for the last time, analytics allows you to do prospective action, identifying in the patient's care what was missed and what can be done to improve the quality. For immediate effort, the administration team that often has a lot of conflict with the clinicians can be roll up their sleeves and bring in the patients and make sure we are taking care of the population much more carefully and much more considerations that would result in better outcomes. Once, when I was in a very large health organization, and we were a billion-dollar company, a $6 billion group, we were having a staff meeting, and I asked one of the guys, who are you and what's your role? He got up and said, I'm an IT man and I'm looking after the databases. And I turned to the rest of the crowd and said, did he describe himself correctly? Then he didn't get my question. But then I had to explain to them that you are a healthcare worker who manages data for healthcare. That a sense of urgency that comes from being a healthcare worker needs to be emphasized in the orientation to everybody. An ambulance driver is a driver, but when he says the word ambulance, people give him respect and they say, okay, we need to let him go through first. In a similar fashion, we need to get more value and respect and engagement within our teams itself to get forward. This is something I developed using, my organization used an EMR called from GE. I won't say what it's called, I'm not here for commercials, but we integrated the gaps in care right there for the physician, just as they were looking at the point, and on the click on the gaps in care, they came to this page which allowed them to see a composite view of all dimensions of a patient, the 360 view as they call it. The first line itself is all about the basic PHI, and the second row tells you the financial impact of that patient's care service that our doctors were making. So that it is called MLR, medical loss ratio, and the medical risk advantage risk ratio. So those are the ratios you do when you to find out if you have negotiated a good contract with the insurance to take care of the person, and B, if you are being effective in your care. Of course, then you have the medical elements like all the diagnoses that have been part of the medical MRA score are called HCCs. And then, where do we spend the most money? In medications. And despite the fact we are hearing about healthcare seeing reform in America, 600 physicians in the United States today sent out an open letter to the president-elect. They said, before you rip and replace, please renegotiate the costs of medications. Medications are expensive. There may be some pharmaceutical leadership on this call, this webinar. I have no way to say anything, but thanks to the Indian pharmaceutical industry that has been a mainstay in keeping the costs down. So what's the population view? Looking at each clinic and finding out by each ICD what's their census for those patients. I am a pulmonologist, so I look at COPD. And I decided to take one ICD diagnosis and show you the percentage of patients in the clinics I was looking after as a CIO. And if you notice, the area Conway seems to have a very high incidence as a percentage of their practice of COPD, along with Edgewood. And these two communities are actually very next to each other in Orlando. What's it? Is it just because they were all smokers, or is there something else happening there? We don't know, and this is a question which I will revisit using Indian data. But it gives you an opportunity to say, the people in a pop cup all seem to be very healthy as far as COPD goes. But then if you look at it, the people living there, the age population, or whatever it is, something is there which differs. And that would allow you to understand your population better. And such introspection is essential to prepare a physician to be more effective in their care. So this is once again the gaps in care that allow you to jump in and check what the patient has and intervene in time. Now, we got that population list. If you clicked on that list and you look for all patients who had it, you could get a list. And then you could take that list and share it. If you see add share, you could share it with somebody, and then you could load it and you could send it to somebody in the staff. Hey, I want to get all these patients in. So you see that data that was so much looking like the preventive social medicine epidemiology suddenly turns active and becomes part of care delivery. That's the transformation we need. And when the person has seen it, you can check and find out if it was seen, and then you can track it back. We talked about resource utilization. One of the areas of resource utilization that is critical is referrals. There are certain doctors who have an MRI investment. Should they send all their patients for MRI? I'm not going to be the judge of things, but if we are going to let the physician heal thyself, or physician begin by curing himself of this problem, we need to be able to give them data and show them that the patients that you sent out, these are the numbers, and by these specialists, and if you click on any of these numbers, you would see the specialists you referred these patients to. And if you want to be still interested, you can click and find out how much did referral billing cost. Now, in India, we still leave it for the patient to pay the bill. So maybe you'll say it's not my problem. Sir, it is your problem because the other doctor could take away your patient. And if you notice, it is happening. The Diwali sweet packets you gave to your friends to make sure you're still in their referral chain will soon be modifying when people will start looking at data and changing. That day is not far away. And I've been in the field of medical informatics for over 30 years, and I can only tell you, many of the dreams we had are now reality. These are some of the realities I'm sharing with you. So the innovation further is still ahead. You can, I'm keeping it blurred because there are names of people, but you can actually see how many things were you given to that person, what did you do, what's the activity level, and with that you can even now assess your administrative operations to recognize who is your effective partner or employee. Now let's switch for a moment because my colleagues in Cloud9 Hospital were kind enough to share value and make it locally relevant. So one of the things they're developing is an architecture for machine learning, because we want to see associations that exist and then maybe have a smaller group evaluate it to find out if the relationship is causal or coincidental. And if it is causal and coincidental, where lies the causality and what can we do to improve upon it? That's one dimension of it. It's an early effort. We are on that track, and this is from Cloud9. We looked at the 2 million, is it 226,000? Yeah, it's about 225,000 encounters. And we found that the ICD code 917 had nearly a sizable number of patients. There's 26%, nearly over 26,000, 27,000 patients. And looking at all this data, now you start seeing, you can get a picture of what is happening in your population. They found there were many low-weight babies. If they are low-weight, having had a granddaughter born was barely 900 grams. To me, 2.25 kilos is a very big baby. But the fact is, as the data tells you here, the low birth weight curve is very clear in the population that Cloud9 was taking care of. And to see the URI was highest where it was in those babies less than 3.75 and more than 2.25. Others, whether they survived or not, we don't know. And this is the interesting thing. Once we had that data, we went in with, once we had the population with upper respiratory infection in infants, when we laid it over with the data of the weather, we found that they find as soon as it becomes a little cooler in Bengaluru, that the incidence of upper respiratory tract infection rises. This is one for educating the patient to keep the child warm or make preventive measures. This information also has clinical value in the sense that when you see a child who's not thriving, make some effort to help them. And as administrators of the organization, you can use the same data to realize that once the weather gets a little mild and wet, let's raise the possibilities of taking care of a rising census in the hospital for children with acute upper respiratory infection. So it comes to the point when I'm about to close, so I'll say, what is the big thing? Is it big data or is it big decision? What is big? I like to say, as a pulmonologist, when I'm told a patient can't breathe and I find his PaO2 level has fallen, I cut his throat, do a tracheostomy. What is big? The data were only two simple elements. The decision to cut the throat was very big. So this is something we got to recognize and recognize very carefully, because the decision-making models of our clinicians is to make mega decisions with minimum data. Whereas for operations, we make minimum decisions with mega data. So we got to find a fine balance. And I'm sorry for the wrong spelling of Werables. And I want to take you to this slide on Werables for chronic care management. The life is changing here. Data that we already collect is there. But this is the explosion that's going to happen. We better be ready for it. All these devices that were developed by others, people who made maps have now started making devices for heart rate monitoring, to walking steps, counting your walking steps, etc., etc. Then you have another company called Vivify, and they get into clinical solutions that are specific and allow patients with high blood pressure, heart failure, blood glucose, diabetic issues to think up how to do. This company, Blip, has an Indian relationship, and they do very well. They sell their devices on Amazon, and you can take care of yourself. As a matter of fact, I have Blip implemented in my mother's home, so when she climbs up on her weight, I keep track of it, and if the day she concedes to give me her blood pressure, we know about it, so we have a conversation. It is changing things, and this is where the future is. No longer will you discharge a patient. No longer will you discharge a patient with chronic care issues. You will only modify their site of care from office to home, to office, to hospital, and that cycle means you need to be in perceptively constant engagement with your patient. And what is that all about? It's getting data. This is a group that won the tricorder contest held by Qualcomm, and these very futuristic looking things are all designed to only look after the healthy. They tell you when you're doing your exercise. I think it's a balance. We need healthy people to keeping themselves healthy, but as care delivery people, we are trained to look after the unhealthy, and that will remain our challenge. Lots of devices are coming up. This is from an article in Nature. You can see the number of vendors sharing number of things, including lens that will be implemented in your eyes that will monitor your glucose. How about that? So you like it or not, you're going to be monitored. And when you take your medications, things like Proteus will track the pill once it passes the stomach, and the physician will get an accurate display of when was the medicine taken. So, interestingly, we found in some of our studies that blood pressure shoots up on the weekend. When you think the person's at home, should have no stress. Actually, we have the greatest stress because when you stay home on Friday, there's a binge party, or you end up going for movies and this and that. It's a heavier schedule than the workday schedule. So all of you workaholics, tell your families, my chances of getting a heart attack on Monday are higher due to the stress of staying home on the weekend. Thanks, V K Singh, sir. I'll leave the 10 minutes as you suggested for questions.
Thank you very much, Professor Moidu. It was very interesting. At least I learned many things from today's webinar. Yeah, and I'm sure the viewers from across the globe who are attending it also must have been benefited.
When you say globe, I need to apologize for people for me slipping into Hindi and Indian orientation from time to time.
Yeah, okay.
Thank you. You should have warned me, sir.
Yeah. Now I request the people to ask for the questions, and whatever the question will come, I'll forward it to Professor Moidu, and then he will answer. And after all the question and answer, we would also sum it up. Thank you.
So Professor Moidu, there is a question tab somewhere in your screen, and I have already assigned first question from Manish Sharma. Can you see it?
Yes, I do see it, and the gentleman has a very technically related question. Manish Sharma Ji wants to know about machine learning. Now, the beauty about medicine and medical care is It's not an exact science. No two bodies respond to the same drug in the same way. So while you say the methodology applied is tagging and labeling to identify objects and data, your question gets even deeper by asking, how do we improve or ensure clinical data recording is good and benefits the machine learning in providing insights and recommendations? My answer is very simple, sir. The data entered must be used by the person who entered the data. Else, it's garbage in, garbage out. GIGO. Mr. Naveen Gowda, thank you very much for your kind words, sir. Any other questions are more than welcome. It's a good question from Naveen. How do we use video recordings as a tool for data extraction? The answer is simple. If you keep the data as a video or an audio recording, you should allow for a person to comment on it. Now, as a pulmonologist, I will hear something different than perhaps a general physician. But if you gave me the audio and you allow the primary care physician to write their note, and then I write a note, and you now have two elements of data describing the same event, the question is, who do you trust? Trust comes from clinical relevance, and I have used video recordings as far back as in '95 when we did our first telemedicine project in Connecticut, when we would have clinical encounters and we kept those elements captured and we created a multimedia record. That day is not far, sir. The current models were based on what we were already doing with our paper, and there will be more of that happening. The challenge of unstructured data, just want to tell you, even when you structure it, if the word dizziness comes, just be ready to get dizzy. Dizziness has 28 reasons, and when you look at even the SNOMED codes, each of them even codified would become 28 different elements. So yes, the English language is what we use, but we have a very paucity of expression. And that natural language, much as I believe people believe it will happen, is not in my lifetime. It's improving. I'm going to get summaries, but that doesn't mean we will accept it. And for Dr. Sudhir, the head of Shankara Nethralaya, I can tell you, sir, there's nothing more structured than an ophthalmology document. And having had my cataract removed a year plus ago, I can tell you in 3.5 minutes, he did each eye. I thought there was so much precision in it. But when I needed that cataract operation, I went to 17 doctors, listened to how they do it, and told them, am I the right candidate for laser or not? Tell me. And why did I ask that question is because laser began in '98. I graduated 27 years before that. And yes, I stay current with my reading, but to become an expert overnight is not possible. So much appreciate your thinking. Are pharma industries interested in buying medical data analytics? Yes, it has been the source of it. Merck bought a home pharmacy company called Medco in 1993 for $4 billion then. And that's the day I hung a poster outside my office that there are 4 billion reasons why I will have a job. Because those days in '93, '94, people used to wonder, What are you doing as medical informatics in our office? Go look at patients, man. Don't give us talk on data. But today, after 20 plus years since that day, I want to tell you, yes, there is a value, but is your data right? Or is your data going to be the debate? That's the question. And I think that's the question Mr. Manish asked, and I thank you very much for asking that question to Geeta. When we try to work with hospitals in the field of analytics, one of the concerns we hear is regarding data security. That's an obstructionist. That is an obstructionist. I did my analytics for my group in Orlando. I had 7 programmers. I went, my company said, we need analytics. What do? I said, sir, brought in all the big companies, IBM included. And guess what? Those millions they were asking was too much. I told my company, give me $300,000 for 3 years. They didn't understand me right. They gave me $1 million for 3 years. What I meant was $300,000 over 3 years. And I hired 6 people in Chennai. And I had one of them by rotation go through Orlando, while the other 5 sat in Chennai. And we worked through. And the gaps in care, the reference module, and the pieces I shared with you all from my experience were all done in about 180 days. Productivity lies in how you construct the plan. And that's where I like to say, when you talk to analysts, and especially people who talk machine learning, statistics, data scientists, you have to bring them a peg down and help them understand. If you don't understand it in the context of care, it's a conversation we don't take very far. And frankly speaking, even as one who's been in the field for all these years, I can tell you, it's like the trip of Alice in Wonderland. You don't know around each corner what are you going to see. So to say predictive analytics is there and it's going to make it happen, I don't know. In a few days, you have a meeting. Yes, sir.
The last question, if you can take that one, because the time is just after 2 minutes. This is written about the EMR by Nimisha Singh. And after that, we'll not take any more questions. And then I'll sum it up because of the time constraint. Thank you, Professor.
Sure, sir. Nimisha ji, you asked a very important question. In the current state of our electronic medical records, the electronic medical record is a simple data capture solution. Over time, for business reporting and compliance requirements, we have placed on the top of the EMR solutions that are called analytical applications. Today, we still look at systems as monoliths, but I look at it tomorrow where we'll have a lot of apps running around, and each of those apps would be a different way to pull and push data. Standards of FHIR are also described as FIRE by HL7 will allow us to pull data faster and respond and give the ability for a neurologist to work with the data with as much comfort as a gastroenterologist. I don't have to read the 66 pages long record of a gastroenterologist because relevance to my care may be 5 issues. And tomorrow is coming. The innovation is got to start. I hope Innovation Curious sets up an innovation lab and look at new design because the old one will only take you that far. It's like aircrafts. You need to really re-engineer from start. And that's why there's a future that is still there to come.
Thank you very much, Professor Moidu, for spending your time and making us really more knowledgeable on the subject, and the viewer has appreciated it. We'll take it forward. We'll have continuous dialogue with you time to time. And I'm sure when you come in India, we'll have something physical, some kind of a training, which we have talked that we are developing. We already launched Innovators Club, which will have first meeting in January. We also have a quarterly magazine. Next one is under print. The next one will be in January. Conference and Innovation Week will be Sunday, 18 April next year. Webinar, we are doing training along with you. We'll be doing it so that this is more awareness and people available for this job. We will be sending you all the emails we have now from you. All this, what I'm talking, the activity, the link of this, and we'll keep you informed. Once again, I thank Professor Moidu, Sachin, and all participants for spending their valuable time. Thank you very much, and good day for you, and good night for the Indians.
Thank you, sir.
Thank you.